Okay, good morning, everyone. I think we should get started. So welcome back. I believe this is our second content-based based session. So for the last session, what we have done over the last few years is to collect some outstanding questions that you might have based on this series that we haven't covered. And this has traditionally been one of the most useful sessions because we don't know everything that people want to learn. And it's a good opportunity to review things as well as to address any remaining issues that deal with health equity and cardiovascular risk. Just the usual reminders, please don't disclose any private health information in the case studies. These are our contacts about cardio once again. And today I'll be facilitating as always. And I'm very privileged to have George presenting this morning. I've worked with George for a few years now. He was one of our residents in family medicine and preventive medicine, and has a interest in a special population we don't usually think of as being prone to cardiovascular risk. But I think it's really important for us to discuss this in terms of issues of access and special needs, etc. Our discussants are going to be Danette, Chris, and myself. And we have two cases from Emily Boyd and Megan Sizemore. So let me move on. No new disclosures. And with that introduction, George, please take it away. Thank you.
All right. Thank you, Dr. Rao. So today we're going to be talking about health equity among sexual and gender minorities. Learning objectives for today, providing an overview of increased cardiovascular risk, including potential causes among LGBTQ patients, and describing that culturally sensitive and effective strategies for communicating cardiovascular risk to these patients, and how to create that welcoming environment for patients to be able to seek care. So to start, I wanted to go through a glossary of terms for LGBTQ health. We have heard of bisexual, gay, lesbian. These terms have been thrown out there, but some that I wanted to review pretty quickly were gender expression, gender identity, and gender minority. So gender expression is the way in which a person communicates their femininity, masculinity, or other aspects of their gender, often through the way they speak, their gait, their style of dress. Everyone does have a way in which they express their gender. Gender identity is a person's inner sense of being a woman, a man, a combination of the two, something else, or even having no gender at all. And everyone does have a gender identity as well. A gender minority are a broad diversity of people who have this incongruence with their gender identity. So these would be individuals who identify as transgender and gender non-binary people. Moving forward on this table, sexual minority, which is in our topic for today, is a broad diversity of people who have a sexual orientation that is anything other than heterosexual, straight, and typically includes gay, bisexual, lesbian, queer, or something else. Another term that wasn't listed on this table that's worth discussing is gender dysphoria. So that's a term that describes a sense of unease that a person may have because of that mismatch between their biological sex and their gender identity. The reason I bring this term up is because this is actually a billable ICD-10 diagnosis to cover gender-affirming care. So this would be the diagnosis you'd bill if you're trying to prescribe estrogen or testosterone to one of our gender care patients. So let's summarize cardiovascular health in this population. So there's approximately 11 million LGBTQ adults in the US that are part of this marginalized group that do have significant health disparities. Only recently, as of 2017 onwards, do we really have any good data that kind of tells us about these different health disparities. One of the surveillance systems, a behavioral risk factor surveillance system, has actually documented that there's a higher prevalence of self-reported tobacco use and cardiovascular disease diagnoses in gender minority adults. And we're working on including transgender markers in more surveillance systems nationally to be able to collect this data. The predominant theory that really explains LGBTQ health disparities is what's called the minority stress model. And several associations have utilized this minority stress model to show why we have these health disparities within the LGBTQ community. And this could be due to multi-level stressors that are intrapersonal, interpersonal, structural, that may contribute to this. So Here we have a conceptual model of cardiovascular health in LGBTQ adults that was created by the American Heart Association that utilized that minority stress model. I really like this flow chart here because it really goes through, why we have cardiovascular risk factors in this patient population. So kind of going from the left to the right, we have our minority group, the LGBTQ group. Then we see that there's several life stressors from different aspects of life. So generally speaking, there may be financial stressors, work stressors, family stress, violence due to their LGBTQ identity, structural or institutional wise, where do these individuals live? Are there laws that prohibit them from seeking care due to what kind of therapy they're looking for? What are the social norms in the environment that these individuals live in? Interpersonal care. So these are prejudiced events. Are they facing discrimination, violence? And then there's intrapersonal, which is self-stigma, expectations of rejection. For example, many of these patients will go to their physician's offices or healthcare providers' offices with this expectation that they won't get the care they need, they will be judged. So this is something important to note as well. Psychosocial factors that then result from these life stressors. So there's psychopathology. So these individuals will usually have a higher rate of depression, stress, anxiety, which we know plays a role in increased cardiovascular risk. There's also behavioral factors. So these individuals are much more likely to use tobacco, have a poor diet, which may be due to financial strain, less physical activity, which also may be due to fear of violence going out into the community. Then there's the physiological factors as well. Now, before we move forward, there's a box in the bottom left that talks about social and clinical determinants. So in this box, these factors can be, sprinkled into this model and anywhere in this model. And sexual orientation is on there, HIV status is on there, hormone status is on there. We're going to be talking about some of these things moving forward in the presentation. But knowing what is the genetics of the patients you're working with, are they on medications that put them at an increased cardiovascular risk? So these are important things to know when working with the LGBTQ population. So what are some of these additional risk factors? So I mentioned HIV. So transgender women and sexual minority men have a disproportionate burden of HIV compared with non-LGBTQ individuals. So we know this because we have a lot of data from the CDC. I put a table on the right that shows the new HIV diagnoses in the US from 2021. And you can see this was just for male-to-male sexual contact. The transgender female chart is very similar to this one, where there's many more individuals who are having new HIV diagnoses that are having this male-to-male sexual contact. And this is for children age 13 and older. So this is a true issue that needs to be addressed. But the reason I bring this up is because we know that with HIV, there's an increased risk of cardiovascular disease because of a high prevalence of CVD risk behaviors among this patient population, dyslipidemia and other cardiometabolic changes associated with certain HIV treatments, and there's the physiological effects of HIV disease itself. So this is another important thing to know when treating this patient population. Moving forward, we have the use of gender-affirming hormone therapy, which has been identified as a potential contributor to poor cardiovascular health because of the cardiovascular effects of some of these treatments. So to the right is a study that was published with the American College of Cardiology that talked about the cardiovascular outcomes in gender dysphoric patients who underwent hormone replacement therapy. So there were 1,675 individuals who were on hormone therapy. And they had seen that with these individuals, there was an increased risk of ischemic stroke, pulmonary embolism, STEMI, and STEMI drug abuse and hypothyroidism. Now, to note, most of these individuals fell into the elder male at birth group. So we're not only working with transgender individuals in this study, but we also have older, elderly men at birth who we know are at increased risk of cardiovascular disease as well. So not only are they on hormone therapy, which is likely to be estrogen replacement therapy, but they're also on, have that factor as well of being male at birth. I wanted to go through the effects of estrogen and testosterone and what are some of the risks that we can see with these two different medications. So with estrogen, there is that increased risk of blood clots, gallstones, elevated liver enzymes, weight gain, hypertriglyceridemia, and there is that likely increased risk of cardiovascular disease. You can see hypertension, possibly can see diabetes as well. But this is just something important to note. This is actually taken from a table that we share with our patients in the clinic. We sit down, we go through step by step what to expect when starting estrogen or testosterone, and what are the risks that we can see with these different medications. Now, to the left, I have several images of different formulations of estradiol, which is what we prescribe for, typically for men who are transitioning to women, for trans women. And what we do for our patients is we look at their risk and then we decide what formulation is best for them. So if we do have an elderly male who may have hypercholesterolemia and other risk factors, we would opt for a transdermal approach of estrogen versus a PO tablet or intramuscular injection, because it bypasses that first pass metabolism. So we're also, if they do have hypercholesterolemia or some other risk factors, we bypass that. In addition, we have microdosing of estradiol through the transdermal patch, so they're not getting as much estradiol at one go. So that's something that we do in our clinic if we have a patient who may be at a higher risk. For testosterone, the likely increased risk is polycythemia, weight gain, acne, androgenic alopecia, sleep apnea. We also see elevated liver enzymes as well. Again, taking into account the patient, you can decide whether you want to do an intramuscular injection versus a topical gel. That's just something else to keep in mind as well. So what do we do then for our individuals who are at a higher cardiovascular risk, particularly our trans patients? Do we give them hormone replacement therapy? Do we not? What can we do? So the answer is yes and no. It's a shared decision-making process. And what a lot of people don't know is that when you do seek gender-affirming care for these individuals, you don't have to necessarily prescribe estrogen or testosterone. There are other medications as well that we can use, and not only medications, but other resources that are available in the community to help this patient population. So for example, for feminizing hormone therapy, we typically use estradiol, but I have some patients that we use spironolactone for, which is basically a testosterone blocker. So it's a blocker that will allow the testosterone levels to drop, and these patients will actually have symptoms, which is what they're seeking, of gynecomastia, as well as decreased erectile function, etc. That actually may be all they want or all they need, and that might be what they're seeking. So we don't necessarily need to start these individuals on these hormone replacement therapies if that's not exactly what they're seeking, or if they're at higher risk. So talking about this patient population, the reason why it's really important to work with these individuals and find out what they need and kind of meet them where they're at is because we have a lot of data that shows that a lot of our transgender patients are going to the emergency room to get primary care. About 21% avoid the emergency room because of this fear of discrimination. There's a much higher likelihood of attempting suicide, higher HIV infection rate, as we already mentioned, higher rate of drug use, sexual assault, domestic violence, and sex work, extreme poverty, unemployed, the list goes on. So this is a patient population that's very vulnerable, and trying to find a way to meet their needs is important, because some of my trans patients, for example, will come to me for gender-affirming care, and I may be the first individual they've seen in years for any primary care purposes at all. So then it's my job to try to have them catch up with their primary care needs, but a lot of the time they won't seek that unless I actually try to address their need to seek hormone replacement therapy or a different form of gender-affirming care. So wanted to jump into culturally competent care. How can we create culturally competent care with our practice? So there's many ways to do this. One of the ways is to advertise the practice as accepting of members of the LGBTQ community, educating staff and providers to be comfortable in discussing sexual orientation, gender orientation, and sexual practices, Include members of the LGBTQ community as part of your staff, and train your staff to refer to patients by their name and chosen descriptive pronouns. Maintaining an open mind and avoiding judgment regarding sexual orientation and practices. On intake forms in the office, include the term partner in addition to spouse, and including transgender as an option. Participating in referral programs such as the Gay Lesbian Medical Association or Gay Health. That is actually free to sign up for and put your name on the GLMA directory. Highly encourage that for all individuals, not only individuals who are providing gender affirming care. This lets patients know that you're a provider who is aware of the LGBTQ community and is approachable, so that patients will actually seek primary care. In addition, posting LGBTQ symbols and posters of ethnically and racially diverse transgender or same-sex couples in the clinic. Providing brochures on sexually transmitted infection prevention, substance abuse, safe sex practices, hormone therapy. Waiting room magazines about the LGBTQ community, and even observing special days within the LGBTQ community, such as Pride Day, World AIDS Day, National Transgender Day of Remembrance. And lastly, routinely training staff and providing continuing education on the care of LGBTQ patients. So these are just, these are several examples of ways that we can provide culturally competent care in the primary care setting and outside of the primary care setting that I wanted to share. Now, this is my last slide. I actually got this from the Clinician's Guide of LGBTQ Care. I really liked this image because it shows how we connect cultural competency to cultural safety. So working from the smaller circle out, we have the patient's culture, which can be complex, multi-layered. It includes the patient's identity, race, class, incarceration risk, disability. These are just important things to note about the patient's culture. Then moving up, we see cultural sensitivity and proficiency and awareness. So that's the knowledge that there are cultural differences accompanied by a willingness to learn. And we see those two arrows coming out. We need to really understand our patients' activities of daily living, what they're going through. Then also focusing on patient-centered goals and what are the goals that the patients are seeking. If we don't incorporate our patients' goals into our care, they're likely not going to, cooperate / be able to do what we're trying to tell them to do, because they have other needs that are more pressing for them that need to be addressed. Then moving up, cultural competency. So this is where we as healthcare practitioners are at the center of making sure we have the knowledge and training to take care of different patient populations, including the LGBTQ community. So how do we do this? We do this through partnerships with LGBTQ community groups, prioritizing, the patient's narrative, using our knowledge that we've accumulated and the patient's knowledge that they've given us to create this plan for the both of us. And lastly, the goal is cultural safety. So transferring that power to the patient. So making sure that the patient feels that they have the power to make their medical decisions. We are there as their liaison for their clinical care and helping them seek the care they need. So overall, the goal with LGBTQ-centered care is understanding our patient, understanding what are their needs, what can we do to help set them up with different community partners, not necessarily only medication and medication, but what can we do outside of that setting to make sure that they have all their needs addressed. And that was my last slide. So I'm happy to take any questions.
Thank you, George. Terrific presentation and lots of great points there. Just had more of almost a technical question. You talked about transdermal estrogen therapy as an alternative to intramuscular therapy for some patients that are at a higher cardiovascular risk. Is that as effective? And if it is, why not use it all the time?
So it is as effective. It just would take longer to to increase the dose and get to the likely dose that the patient needs. A lot of patients want to see their results quicker. So if they are younger, you can opt for PO versus intramuscular. But more often than not, I do use transdermal. If the patient's agreeable, I'll usually bring that up first and we'll go that route and just work slowly through increasing the estrogen levels. It just really depends on the patient, what they're wanting. And a lot of them don't, really want to see those results quicker. So that's how I decide whether I choose one versus the other.
Thank you. Any additional questions for George?
Are the prior authorizations with transdermal versus like the PO route, is that also kind of maybe a deterrence too of using that, or?
So, sometimes I do have to get prior authorization, usually not for PO. For the PO option, it's usually covered. But the transdermal and intramuscular often do need prior auth. I usually will submit the prior auth, and I don't really have any issues getting it approved, but it's just that waiting period of going through the prior auth.
Okay.
Let me turn things over to Andy for a moment.
Thank you. Just another reminder that you can access all past and present Echo Clinic recordings on the Cardio website. A reminder that our next Cardio webinar is coming up in February. You can register on Cardio's website as well. I sent an email to you all last week, but we are repeating this Echo series next year for the spring 2024 Echo. We would love to see you all there. You can register online, and I sent an email kind of explaining the benefits of repeating the series. And then final reminders, you should have a post-clinic survey emailed to you. Please complete that by tomorrow. And as Gautam said, please email me or include in your survey any questions you would like to bring up in the wrap-up clinic, and I'll send a follow-up email tomorrow about that.
All right. Thank you, everyone. Enjoy the rest of the week, and we'll see you next week. Take care.